Good morning, friends. IAOS is proud to present the world's first UVBI EBOO filter-free system. The video shows the detailed steps of the procedure of performing this filter-free UVBI EBOO. First of all, 300 ml or 3000 international unit or 0.6 ml of heparin is mixed with 4 ml of distilled water, capped and kept aside. For all blood procedures, gloves must be used. 0.6 ml of heparin is drawn. And this is mixed with water for injection to make it 5 ml of diluted heparin. The needle is capped and the syringe is kept aside because once we get the vein and the menflon inserted, these syringes will be used for flushing and testing the patency. The same procedure is repeated with another syringe, and again 0.6 ml, that is 3000 international units of heparin is drawn, mixed with 5 ml of blood and kept aside. One must cap the syringes, that is, cover the needle with a sterile needle stopper that comes with the syringe, and the needle is removed later when we will introduce it into the vein to test the patency. Now we attach the UV hanger for the EBOO system. This is a plastic hanger in which the EBOO bottle will be kept and has ultraviolet rays at wavelength of 245, which have the highest antibacterial, antiviral, antiparasitic activity. The IAOS perfusion pump is now checked and the UV hanger is switched on. We ensure that the pump and lights are working. We regulate the speed and reduce it to 10 ml per minute, which is going to be the lowest to start with, and we can later increase it up to 40 to 60 ml per minute. Now we have to insert the venflons into the donor site. The large venflon is preferred for easier flow, but in case the vein is small, we use a thicker venflon. Once the vein is located, we can mix 4 ml of heparin in a 500 ml saline bottle, which shall be used at a later stage. This patient is suffering from polyarticular rheumatoid arthritis with a subluxed elbow. Fortunately, her veins are good. However, I had anticipated that this vein might counter, so we had kept a butterfly ready for the other vein should any complications occur here. The instant the vein is found, The heparinized syringe is plugged in and the patency is tested by injecting and withdrawing. So we can see that it is patent. Now the venflon is capped in the place and a syringe is retained in situ. The IAOS EBOO set 1 is opened, connected to the heparin saline bottle and the perfusion pump. The lure connection now is attached to the venflon of the donor site from which the syringe has been removed. The bulb with filter is inserted into the EBOO bottle, while the bulb without filter is inserted into the heparin bottle. The EBOO flask is placed in a special UVBI holder and we wait for the flask to be 60% full of blood. So here a sterile EBOO bottle is being opened. Both the top and bottom are removed. There is an arrow that shows which is the top and which is the bottom. We have put it inside the ultraviolet blood irradiation chamber. This is EBOO set number 1. It is sterile, double wrapped and specially invented and designed by IAOS. Patent is pending. Now you can see that it is at this stage I had forgotten to keep the heparin saline ready. So at this stage I am drawing 4 ml or approximately 40,000 ml, 40,000 international units of heparin, and this is put into a 500 milliliter normal saline bottle. The bottle is shaken and we ensure that the heparin is thoroughly mixed in this saline bottle. This is held by the assistant. Now the IAOS EBOO set 1 is opened. The end with a bulb, the bulb with a filter in it, goes into the top of the blood in part of the EBOO bottle. The flow part is opened. The bulb without the filter now goes into the heparinized saline bottle. The lure lock portion has to go inside the patient and the silicone section after the 3-way has to go into the perfusion pump. It is very important that the silicone part, which is after the 3-way, goes into the perfusion pump, and the silicone part of the pipe, which is before the 3-way, goes into the patient's body. We can see that the tubing goes into the IAOS perfusion pump. Now we have to remove the syringe and attach the lower connection to the Venflon and switch on the perfusion pump so that blood is sucked and slowly raises into the bottle. If the blood is not coming at proper speed, it means that the vein has countered. In this case too, it was found that the vein was countered and we changed it to a butterfly. We can now see that despite using a 19 gauge butterfly, the blood is comfortably flowing into the EBOO bottle. We have not yet started the flow of ozone into the bottle. By adjusting the up and down arrow of the perfusion pump, we can ensure that the right amount of blood is drawn into the EBOO bottle. As I have already mentioned, the Venflon had bulged, so it was immediately replaced by a 19G butterfly, which worked equally well. Now we connect a 16G needle to the ozone out silicon tube, and the regulator is kept at 1/8 or 1/16 to have a 70 to 80 microgram per ml of ozone, and the needle goes through the plus point on the EBOO bottle, which leads straight away to the stainless steel filter, and ozone is bubbled out to ozonate the blood and turn it from venous to cherry red. The recipient site vein is now located, a Venflon put in, the syringe is used to keep the patency in check. Once the blood flows till the lower log, we push this recipient set into the bottom of the bottle, open it, and once the blood flows to the lower log, it is attached to the recipient site. So I am now pushing the blood and allowing its inflow. One step where video has not been taken is the heparin port. We attach a needle, and that needle is connected to a silicone tube which goes into a glass bottle for collecting the foam and the waste products. Now we have to adjust the inflow and outflow, ensuring that the inflow does not exceed the outflow. The bottle remains always half full and it is constantly ozonized. We can see the difference between the conventional venous blood and the ozonized EBOO blood, which is bright red and clear of all oxidative products. The needle connected to another silicone tube is collecting the waste which goes into a glass bottle below. The constant UV radiation of the blood makes it bright red. We adjust the flow to ensure that the input and output is the same speed. We can watch the blood color turn to cherry red even as it is being ultraviolet irradiated, UV irradiated. We usually do this procedure from 20 to 45 minutes. We can achieve high speeds of pumping, and in a period of 45 minutes, up to 2.5 liters of blood can be irradiated and retransfused into the patient. In patients with chronic infection, sepsis, very bad polyarticular rheumatoid arthritis like this patient, or in patients with any bacterial, viral, fungal, helminthic or parasitic infection not responding to medical management or chemotherapy, 1 or 2 sessions of EBOO will ensure that the whole blood is cleared of all toxins and the bacterial or viral load is reduced so considerably that the patient's immune system will manage. In this particular case, the donor side of the patient, even if the ventral fails, you can put a butterfly and extract the blood. You can see the video and you can see the color change of both infusion blood and recipient blood. The patients normally require an EBOO session once a month or once in 2 months. After initial loading of 2 sessions in the first month, the foaming, frothing and overflowing byproducts as a result of oxidation are collected by a silicone tube and go to another bottle. The procedure was continued for a period of 45 minutes in this lady. As our system does not use any renal dialysis filters, the color change is due to hyperoxygenation and blood detoxification only. You can very clearly see the color difference between the in blood and the outflow blood. So this is the whole system in operation. Blood coming from the patient, going into the perfusion pump. From the perfusion pump, it goes to the EBOO bottle, which is being radiated. Ozone is coming from the machine. It is going via a filter. The ozonated, irradiated blood is going back into the other side of the patient's body, which is the recipient side. We wait till adequate amount of blood has been recirculated into the patient, and then we must remove the donor site connection and allow all the blood sucked so far to drain into the bottle. If you can see, the bottle level has always been kept at half full. So now we have concluded our session of EBOO, and the nurse has got instructions to detach the donor site and allow the blood from the donor site to drain into the EBOO bottle. Once more, blood from the patient going into the perfusion pump, from the perfusion pump going into the EBOO bottle, ozone being given by a needle, excess foam and froth being removed by another needle which is being kept in a glass bottle. Distinct color change between the blood that goes in and the blood that comes out. If you had paid attention to the heparin bottle, a very small amount of heparin, less than 40 ml, has been used so far and the bottle is full. Now the lower lock is removed to the donor side and the blood is allowed to be drained into the EBOO flask. So the nurse will now remove the donor side and also remove the butterfly and clamp it and pad it so that the patient does not have a post-procedure ooze. As heparin has been used, it is essential to put dense padding and then put a bandage. The moment the butterfly is disconnected, the perfusion pump starts collecting the blood at its own speed, which in our case was 40 ml per minute, and the blood is being pumped. We can increase the speed now because it is no longer connected to the patient, and you can see the blood is rapidly being drawn in and it goes into the EBOO bottle. Our donor site job is over, and so we can remove the pipe from the donor side and set 1 can be discarded along with all its pipings and the heparin flask. We can see less than 100 ml or maybe even less, 50-60 ml of heparin has been used, diluted heparin has been used in our entire 2-liter process. The sets are disposable, though they are costly to procure. It is not possible to clean and sterilize them again, so they are disposed after every use. The machine is switched off and we wait for the remaining blood to flow in the patient. Occasionally, if the blood flow is not fast, we can put an air vent on the top to ensure that the entire blood drains into the bottom patient. Still about half of the EBOO flask is full of blood which is being drained into the recipient site. Meanwhile, we can remove the butterfly from the donor site and use a tight padding and an adhesive plaster so that the site doesn't bleed. We can see the other venflon which had blocked in between the process on the ulnar aspect of the forearm. Rest of the blood is now flowing into the patient, and once the entire blood has drained into the patient, we can pull the bulb outside and the ozone pipe is removed, ozone is stopped, the regulator is brought to zero, and opposite side air vent is put, and the last of the blood is allowed to drain into the patient. If the blood flow is not good, we can remove the bulb from the bottle and raise it to a higher level to allow all the blood to go back in the patient. We are not removing the recipient side venflon because the patient is scheduled for intravenous procedure on the next day. In this case, the venflon is retained because she needs additional and subsequent intravenous procedures. If you are interested in learning about this procedure, which in this case reduced her steroid doses by 90% after just 2 doses, and DMARDs are also reduced by more than 60%. More about IAOS UVBI EBOO system, you can message me in this WhatsApp number for complete details. Thank you for enjoying the talk. Thank you.